Welcome, everyone, to the annual John Doris Memorial Lecture. I want to thank you all for coming out today on this beautiful day, finally, a beautiful day. Before we get started, I want to recognize, I'm John Eckenrode, by the way, for people who I haven't met yet. I see some unfamiliar faces, so thank you for coming. I want to recognize a few special guests in the audience. We're very fortunate to have with us today a very good representation from the Doris family. So we have two of John's children here. We have Joan Doris, and she brought her daughter Eileen, so thank you for coming. And we also have Ellen Doris here as well. There she is. And we have Molly Doris Pierce, who's daughter Margaret's daughter, so a granddaughter and she's at William Smith College up in Geneva, a senior. So we have four Doris representatives here today, so that's great. Thank you. I want to also thank Patty Thayer, who's standing in the back, who helped put all this together. And to remind you, there will be a lunch. If you see people quietly in the back as the talk is going on, they'll be setting up lunch, and that'll be after the talk. And you're all invited to stay if you have time and have some lunch and visit with our speaker, our guest, and with each other. So I hope you can stay around for that. Let me say a word about the Bronfenbrenner Center for Translational Research that's hosting this talk. We're a center that promotes the use of science-based evidence in the design of programs and policies to benefit children and families. And we do this in many ways. We certainly, this can mean the development of an evaluation of new programs, especially prevention programs, but it can also mean helping out in the dissemination and implementation of evidence-based programs, whether developed by others or by us, more widely in the state or nationally and internationally. And as you will shortly hear from our speaker today, she has extensively worked in the areas of prevention programming and also in the implementation side of things as well, in the mental health field particularly. This lecture is named after John Doris, as you know. He was the founding director and longstanding director of the Family Life Development Center, which was one of the two parent centers that formed the current Bronfenbrenner Center, which was formed 3 years ago. And I see our current director in the back, Carl Pillemer, is sitting in the back, who's our director of the Bronfenbrenner Center. John Doris's bio is at the back of your program if you're interested, but I wanted to point out here that John's professional life fits particularly well with our speaker's background and the themes of her talk today. John, after all, was trained as a clinical child psychologist at Yale University. He worked there as a chief psychologist at the Yale Child Study Center, and he's also an assistant professor at the Yale's Department of Psychology before he came to Cornell in 1963 as a faculty member. John also had very deep roots in New York City. He was born in the Bronx, and he graduated from the College of the City of New York before going to graduate school. And as a faculty member and director of the FLDC, Dr. Doris, like Professor Hoagwood, also helped to build effective training and research programs in close collaboration with state agencies. In John's case, particularly with the Office of Children and Family Services around issues of child abuse and neglect, work that continues to this day. But he also worked with other agencies as well. So I think his legacy is a particularly good backdrop for today's lecture. So let me say a few words about our speaker, Dr. Kimberly Hoagwood. Oops, changing slides as we speak. Okay, well that was the end of the program. I hope you caught all of that. What's happening, Lisa? What's happening? We need some technical assistance and training here.
It's like time traveling.
It is time travel. I did it, but I don't know how I did it.
Okay.
I won't touch it. Now, for further entertainment, Let me say a few words about our speaker, Dr. Kimberly Hoagwood. She has worn and continues to wear many hats in her professional career. She's currently the Kathy and Stephen Graham Professor of Child and Adolescent Psychiatry at New York University and Vice Chair for Research in the Department of Child and Adolescent Psychiatry at the NYU School of Medicine. She obtained a master's degree in developmental and clinical psychology at Catholic University and then went on to get a PhD in school psychology at the University of Maryland. She has held many clinical and research positions in her career. Early in her career, she was a practicing staff psychologist in residential treatment locations as well as in school settings. And she also has an impressive set of accomplishments as a research psychologist, including 10 years in Washington, D.C., where she became the chief of child and adolescent mental health services research at the National Institute of Mental Health. And during that time, she also worked with the Surgeon General on the National Action Agenda on Children's Mental Health. Dr. Hoagwood then came to New York, where she was the Director of Youth Services and Evaluation Research for the State Office of Mental Health for some years. And she spent then a brief period at Columbia University before moving to NYU, where she's currently at. In addition to her many academic titles, she is also director of the Center for Implementation, Dissemination of Evidence-Based Practices Among States, or IDEAs, funded by the National Institute of Mental Health with a Center grant. Dr. Hoagwood also directs the Clinical Technical Assistance Center funded by the New York State Office of Mental Health with Dr. Mary McKay. She continues to hold a research scientist position within the Division of Children, Youth, and Families at the New York State Office of Mental Health. She's been a prolific researcher and author, and her research has been supported by many federal and foundation grants as well as state contracts. Dr. Hoagwood has served on many national boards and committees devoted to mental health needs of children and adolescents. Needless to say, we are very pleased that Dr. Hoagwood has agreed to take time out of her busy schedule to be with us today and to deliver this very timely lecture and to spend the day with us. So thank you. And please join me now in welcoming Dr. Hoagwood to Cornell and to the BCTR.
Thank you so much. I am really delighted to be here and to honor the legacy of John Doris, and I'm so happy that the family is here for the work that he has done. You know, in addition to what John said, I'm also a mom, and so I'm going to be talking about family issues because those are very important. I'm also an aviator, and I'm going to be talking a little about 3 dimensions and 4 dimensions. So I'm working on my pilot's license, and that gives me a different way of viewing what we're up to from sort of on high. So what I want to talk about today is how we can design a better system for child and family mental health services. To me, this is an absolutely critical time for us to be thinking about this. We have, many of us, all of you I'm sure, have been, who have been working in this field, are struggling with some of the same problems that we've been dealing with for decades, literally decades. We have some opportunities now to make a real difference. And that's what I want to talk about today, and some of the ways in which we could take advantage of changes that are happening and redesign the system. I think the key points are that we see an increase in the numbers of kids with neurodevelopmental and mental health problems, and I'll show you some data on that. The services are not keeping pace, and they never have. The systems to support these have the same problems that we have faced in the past: fragmentation, lack of integration, lack of use of data, etc. But there is a context with healthcare changes that I think gives us an opportunity to do a better job, and I think it's incumbent on us to take advantage of this opportunity and do something. So I'm going to talk about some of that. Okay. All right, let me try. Do it this way. So just in terms of numbers, Neil Halfon, who does phenomenal work, has pointed out the number of children and adolescents at risk, the percent that we're seeing that have numerous problems. And basically, you know, these are the kinds of statistics we've seen for many years. 4 to 8 have significant disabilities. 30 to 40% have some kind of behavioral need. If we look at mental health and substance abuse disorders specifically, about a quarter, is this what? I'm sorry? Oh, it did again. Okay, warn me if that happens, because if I'm looking down here, I might not notice. About a quarter of children have a mental health disorder with impairments, and this comes from the National Comorbidity Study of Adolescents. And the rates of outpatient visits are rising, inpatient visits are rising. We've got lots of bad news, and I'm not going to dwell on the bad news much longer because we have to get to solutions, but I think it's important to be aware of the context. The trend in limitation of activities, so it's one thing to have a diagnosis, it's another to have a functional limitation or disability. And you can see these trends from 1960 up to 2008. Huge increases in the prevalence of these disorders, these conditions for children in the U.S. And interestingly, but unfortunately, we are seeing some of the steepest increases for Black and Hispanic families, with the steeper increases. All right, this pointer is being a little problematic, but steep increases on red is white, the green are for Black families, and the purple 29.1% change for Hispanic. And similarly for race, the lowest income kids, which is the red line at the top, steepest increase, but also higher income families, and that's largely for children and families, or children with autism. So you are seeing some disparities that persist, but we are also seeing with higher income families, these disabilities are continuing to increase. Why that is not entirely clear, but it's likely to be in part a result of poverty, and there's some data that's showing that the increases in poverty, and particularly during the recession time, map onto those increases in the trends that we're seeing in the prevalence of disorders. So there's no question that there is an interaction there. Mental health and health care conditions are on the rise, and the health care costs in our country are being driven by the increased prevalence of chronic illnesses. And for children and adolescents with mental health problems, getting in early makes a huge difference. We know that the 75 to 90% of the adults with serious mental illness had the first indication of that in childhood, under the age of 24 and often under the age of 18. We can identify these problems early, and we can do something about it. As a society, we are not, and that's a problem. So where are we now when it comes to some of the changes in the system? We have had for many years a separate mental health system, a separate substance abuse system, a separate foster care system, separate juvenile justice, etc. What is happening now is that health care changes under the Affordable Care Act and other changes that are happening are putting more emphasis on a number of things that I think are important for us as we're thinking about system redesign. One is that the mental health parity law makes it illegal, basically, to not provide services for somebody with a mental health problem at the same level as they would be expected to get if they had a different type of health issue. So that mental health parity law people were working on that for 30 years, and it is now in effect. It's not necessarily being implemented consistently, but it does exist. The Affordable Care Act expanded Medicaid coverage, so low-income families and kids now have access to coverage for mental health and substance abuse problems that they did not before. And there are new incentives for using data, for using electronic health records, for paying for performance and attending to outcomes. These are huge changes, and our mental health system, by and large, has not been thinking along these lines. It hasn't been geared up for this because that hasn't been the way the system has worked. It's been a fee for service. It's been based on wherever the contractual dollars could come from. This is changing. It's changing in our state here, and it's changing nationally as well. Some of the impact on the states is that there is expansion of Medicaid coverage. There's a shift from mental health as a separate authority to one that is integrated with health. We're seeing more regionalized services. We're seeing mergers of clinics and agencies to be able to contract with managed care. We're seeing much more emphasis on containing costs, on improving access, and on improving outcomes. These aren't bad things. These are things that I think can be important for driving improved quality. But if we're not careful, they could also drive behavior to reduce costs at the expense of good care. And that's the danger, and I think that's something that we have to be aware of and pay attention to. States as a whole nationally have been affected by the fiscal realities of the economic recession and of problems in the reduction of their workforce. And so New York has certainly had its own share of these kinds of issues, but I just want you to get the national picture as well. States are moving towards managed care. In New York State right now, 2016, the adult mental health system will be under managed care, and 2017, most likely, it will be for children. What this is going to mean, I think, is something that many of us are trying to figure out, but it does mean that the interests that I mentioned on costs, on accountability, on pay for performance, on value-based contracting, on revenues, and on evidence-based practices and showing evidence-based practices and outcomes. Those are going to become more salient. And so I think we need to be thinking very carefully about where are those evidence-based practices, where can we get the outcomes, and how do we build that into our systems so that we make sure kids are not shortchanged. And that's important, and that's a worry. It's a worry because these changes are happening for adults first. They're going to happen for children in a secondary way, and to my way of thinking, it ought to be just the reverse, frankly. But at the very least, we need to be prepared for being able to argue for the types of services we think kids and families are going to need and to make sure they get paid for. Evidence-based treatments are, there are many, let me say that. There have been decades of work. When I was at NIMH, I was very fortunate to be there during the time when there was a steep increase in the development of treatments and preventive interventions that were tested through rigorous approaches in order to yield an evidence base. It exists now. States are paying attention. States are paying attention largely on the adult side again, but there is some incursion, I should say, of evidence-based thinking in states, and New York is ahead of the curve. We've had an evidence-based treatment dissemination center for close to 10 years now that New York State has funded, and we continue to work across the state in being able to provide training and consultation on evidence-based treatments. But by and large, when you look across the country, it's still a small proportion of the population that is getting access to it. It looks like it's about 2%, frankly, of the kids nationally that are getting access to evidence-based treatments or interventions in the public sector. 2%. Now that's pathetic. So what does this mean? What are the implications of these changes? Well, states are facing cost constraints, as I said. There are workforce shortages. There will never be enough psychiatrists, psychologists, or social workers to deal with the problems that we see. And the workforce shortages are very, very much in our face. States are supporting evidence-based interventions, but to a limited degree. And so where do we need to be positioning our research so that it's going to be able to inform practice? And how can we use what we know to help redesign a system? Those are really the key questions. What I'm going to do is I'm going to talk about just a couple of studies that we have been doing in our Ideas Center. Our Ideas Center is linked to the Community Technical Assistance Center that the Office of Mental Health funds. And so we have a research center funded by the National Institute of Mental Health, a CTAC that's funded by the New York State Office of Mental Health. And what we're trying to do is position our studies to be maximally informative and helpful to the state policymakers so that what we're learning can be put into put into practice. And so I'm going to talk a little bit about that, and then I'm going to talk about what the elements of system design might be and how we can put it all together. The typical research trajectory is a linear model. You do your efficacy studies, you do your effectiveness studies, then you study the implementation of it. In fact, it's much messier than that if you're trying to do studies that are going to have a policy impact. And this is the model that we use in the Ideas Center, which is based off of Greg Aaron's, Sally Horowitz, and Michael Hurlbert's epis model, which has outer context. I'm going to try this again, but I'm not too hopeful. Okay. On the left, outer context, which is the service environments, the interorganizational environment. Are agencies talking to one another? Are the state systems talking to one another? As well as the consumer support. And then you see that there are innovations, particular evidence-based practices in the middle, that have to fit both the system and they have to fit the organization. So we're trying to position our studies on understanding these organizations, understand the agencies, make sure that it's relevant to what the state needs and wants, and then can we study what the characteristics are of those practices. And then as well as pay attention to the inner context, so the organizational culture, the organizational climate, the work attitudes. And so we don't do all of this at once by any means. Nobody can. It's formidable, and that wouldn't work. But we are taking parts of this with the object to say, can we improve child and family outcomes if we pay attention to the work environment, if we align our studies with what is relevant to the policymakers. So IDEAS is our Advanced Services Research Center funded by the National Institute of Mental Health, and then the Community Technical Assistance Center, CTAC, has many partners, and that, as I mentioned, is funded by OMH. Just a couple of statements about our CTAC, as we call it. Mary McKay and I are the directors of it with Andy Kleek. We started off focusing just on child clinics and just focusing mostly on engagement training and tracking no-show rates. It rapidly grew to an interest in working with all of the clinics across the state, all of the agencies now serving children and in some cases serving adults as well. And those that are now serving residential treatment, those that are providing family support. So it continues to grow. What we are finding is that the main need that the agencies and the clinics and the community partners have right now is around business practices. There's not a lot of evidence based on business practices either. There's some, but not much. But staying in business, facing the fiscal realities, facing the new world order where contracting with managed care is going to be important, where paying for performance is necessary, where you have to show what types of outcomes are resulting from the work you're doing. This is not something that agencies or the staff have been thinking about. I was trained as a psychologist. That wasn't why I went into psychology. People I work with are social workers. That isn't why people went into social work. But it is a reality. And so we spend a lot of time doing webinars, learning collaboratives, in-person training, telephone consultation, and very structured support around business practices. And then the other is on the clinical issues. And so we've spent quite a bit of time on evidence-based engagement training. We are spending quite a bit of time with our Evidence-Based Treatment Dissemination Center on right now on Bruce Shorpita, Eric Deleiden's Managing and Adapting Practice, a Common Factors approach, which I'll say a little bit more about. But the point here is that you can't do one without the other. In order to help agencies and providers do the work that's important in order to get to kid outcomes, we have to pay attention to helping them with revenue cycle, with business practices, with open source, with concurrent documentation, with some of these nitty-gritty things that sound boring, but they're very important, along with clinical training and support. And we have to make sure that any of the clinical training and support is something that's going to be billable. Otherwise, we're irrelevant. And so we are doing a lot with that. We're working with all 340 of the clinics. We are now working with OASAS on the substance abuse side. So actually, altogether, we have 800 agencies that are eligible, that can participate in any of the trainings that are offered for free, and we're trying to be as responsive as possible. I'm going to skip over a couple of slides in the interest of time. These are the range of studies that we are working on. There are, I think last count was 16, and we just had a couple more. These are research studies. And as I mentioned, we're trying to launch any new study that, in a way that will be very specific to informing the state's efforts. So 2 examples that I'm going to spend a little bit of time talking about. One is adoption. Who adopts among the 347 clinics? Who adopts, who doesn't adopt, and why? Will they adopt some of the trainings that are offered? And then secondly, a multifamily group therapy intervention that we have developed in partnership with parent partners, with family members who are part of the workforce. And we've got a couple randomized trials on that, and so I want to talk a little bit about that. Our adoption study came about because when CTAC was funded, part of what we recognized in the first year was that some of the agencies were signing up right and left for anything we had to offer. You know, they were just right there. And there were others that were slower, you know, or didn't adopt anything at all. And we, in working with the state's interest was, we're supporting this TA center. We want to reach everybody if we can, but we also want to be efficient in what we decide to roll out, because it doesn't make sense to roll out everything to everybody if not everybody needs it, is interested, wants it, etc. So can we come up with a better way of being circumspect and smart from the state standpoint about what to roll out and how? So we wanted to characterize adoption patterns, and we wanted to do that based on the number of trainings that were adopted or used, the intensity, the type, and then also we wanted to be able to classify clinics in terms of distinct adopter groups. And this isn't by way of judging any of the clinics, it's by way of understanding who's participating and who isn't and why. So 248 of the 346 clinics participated in something. So that means there were, what, about 100 clinics that didn't participate in anything. The mean was 4.8 trainings, and intensity, basically you see that webinars are by far the most popular. Well, that's kind of obvious, you know, it's easy. You know, sign up for a webinar and you can sit at your desk and maybe you're paying attention, maybe not. I know often I don't. So webinars tend to be used the most. The in-person, that takes additional time. It takes staff time. You got to be able to send people to it. And so that's an investment, frankly, on the part of the clinics. So that's the in-person, about half of the clinics participate in that, and about 20% in a learning collaborative, and I'll say a little bit more about that, but that's an intensive bring together groups of people or teams from your agency in a group setting in order to learn from one another, in order to develop particular goals, in order to track data. And we wanted to look at the difference between business adoption and clinical adoption versus the hybrid. So basically what we found was that low adopters were those that participated in a 1 to 3, medium, 3 to 5, I think I'm getting those numbers right, high adopters, and then we had these super adopters, super high adopters who participated basically in everything. And then we wanted to know, well, why? You know, what's predicting whether these agencies and these clinics are going to participate in the business or the clinical? So we used logistic regression model with odds ratios in order to look at characteristics of these clinics. And basically what we found for business practices is that if you had a large revenue, you were one of the bigger agencies, your gain or loss per service unit was large, and the percentage of clinical staff who were contracted out, you were less likely to participate in the business practices. Well, that kind of makes sense when you think about it. If you're big, you can cover some of the costs. If you have a loss leader over here, you can cover it over there. So you may not really need the business practices. If you have a percentage of clinical staff who are contracted out, then it may not be, as business practices, may not be of interest to you in the same way, because you've got a method for dealing with that. The hospital affiliates also less likely to participate in that. They tend to be larger. For clinical trainings, we found that the total clinical FTEs, how many clinical staff you have, and the percentage of your child population, those were big drivers of whether you're going to participate in clinical trainings. That makes sense too. You know, you got a lot of staff, you got a population of kids, you want to participate. But these kinds of differences are important for figuring out what is going to be helpful, what is going to be the best fit from an organizational standpoint of what is being offered to who's going to participate and why. So this is one small example of a way in which we tried to do a systematic look at the characteristics of the 300 or so clinics participating in order to be able to help OMH decide when next time we're rolling out a particular set of practices, we're going to target this versus another. The other findings that I'm not going to present today, but I think are very interesting, is that we also did a qualitative study of the non-adopters and the high and super adopters, going in to do interviews with the agency directors, with the supervisors, with the frontline staff, to find out what they saw as the barriers or the facilitators to implementing any of this. And very interestingly to me, it was those agencies that had an alignment between the perspective of the agency director and their staff, where they identified the same set of barriers, the same set of facilitators, where they were aligned. Those were the groups, those were the agencies that were adopting at the highest rate. Those where you had a lack of alignment, where the agency director was saying, what we really care about, and the reason we're not doing this is because it's going to be too much time away from what we're doing normally, or we don't have enough time to do this, or we don't have enough money to do this, whereas the clinical staff were saying, we're just burned out. Where there was a misalignment there, in other words, you found that those were the agencies that just weren't going to be participating in anything. I think that's important, that alignment, and it gets to the work around organizational and leadership support and training, which is critical when you are talking about rolling out anything. You can have the best darn program, the best intervention, the most efficacious, effective, multiple randomized trials, but if you're not thinking about the context of the agency and thinking about the leadership values and attitudes, the organizational culture and climate, and whether this particular intervention is going to align with all of that, you're kind of spitting in the wind. And so it's paying attention to all of those facets that I think is really critical, and that's where our implementation science is leading us. Okay, study 2. This is a study specifically of a particular model, a particular evidence-based practice, if you will, but it's not evidence-based practice in the traditional sense, and I'll say a little bit more about that. But it's designed to address the problems of workforce shortages, the problems of no-show rates and engagement, and problems of disruptive behavior disorders, which of course are the most common that are found in our clinics. And so what we did, and Mary McKay has been the lead on this, what we did was we went to the literature, this was a decade ago, to see what do we know about parent management strategies, about effective parent management and parent skills training, and can we take those basic principles and models and make them real and grounded for the multi-ethnic families in New York City? And how are we going to go about doing that? So the first thing we did was we worked with a group of parent partners. New York State, you may or may not know this, but we have a wonderful resource of now 400 parent partners. These are family support specialists, so they're parents of kids whose kids have grown up in the mental health system, who are now wanting to give back and wanting to work side by side with other staff. And so we have developed a training model. This was done with NIMH grant support to provide a credential on a particular set of skills that parent partners can use to be full professional partners in the workforce. It's being done in waiver programs, but it's being done throughout the state. And there are 400 family partners who have been credentialed this way. So we worked with parent partners and with our group of social workers, and we said, well, here's what the literature says. This is what parent management is all about, and it's got all this fancy language to it. And this is what it's all, what we're really doing, and did some of the role playing and working with families, and then asked the parent partners, how would you talk about this? How do you describe this? And basically, so these, child management skills, family communication, within family support, et cetera. And what the families told us is, well, it's 4 R's and 2 S's. Okay, I like that. That's really a simple way to do it. You could put that on a mug, 4 R's and 2 S's. You could put it on a magnet on your refrigerator. Rules, roles, and responsibilities, respectful communications, relationships, and then stress and support. And really, those are the basic principles that are part of what we know from decades of work on parent management. So this is also called 4 R's and 2 S's. We did our first study in New York City, and this was with low-income families, multi-ethnic families. And the basic model is 6 to 8 families of kids with disruptive behavior problems. Think of a room full, 6 to 8 families with kids with these kinds of issues. Co-led by a social worker and by a parent partner. Very trained, very supervised, very supported. And we keep these the families together for up to 16 weeks, but it doesn't sound it's not as bad as it sounds, because we do the same kinds of cycles twice. So it's more like an 8-week, but because we know life intervenes, families can't always show up, we have a sort of cycle of sessions that enables everybody to come when they can, but it's altogether 16 weeks. And then we looked at the outcomes from this versus treatment as usual. And basically, and this was at 6 months, and then we followed them up to 18 months. And basically what we have found is that in any of the primary outcomes that we were looking at, so child disruptive behavior, obviously, impairment in peer relations, impairment in functioning, social skills, we saw effect sizes that ranged from 0.29 or so to 0.91. So, quite a range, but fairly robust, and effect sizes between the two conditions, the experimental and the control that you can see here, in favor of this model. So in terms of what we were targeting, which was improving child outcomes, also improving parent outcomes, parent support, we have found that this was effective. Now, what we also found was that we were burning out the case managers who were running these groups. This is hard stuff to do, and many people are not taught how to run groups, and it is exhausting. So we've found that in terms of the implementation of this, we've had to provide additional support. We've had to embed a quality improvement team within the agencies that can help make this implementable. So that means you've got to be able to bill for group work. You've got to be able to have a caseload that's going to be adjusted if you're running these groups. You've got to be able to meet at other hours of the day, and you've got to be able to track data. So we are now doing a second test of this. I think I have this here. A second test of this, which is looking at both a replication of the effectiveness trial, but also a implementation quality improvement team that's going to be built in along with the training on this particular model to see if that will improve both the fidelity to the model and the sustainability of it. I think that the main point here is what I'd said before. It's great to have an effective program or intervention, whatever you want to call it, but to actually get it to be used, to be accepted, to be sustained, takes additional kinds of supports, but we can systematize that too. We can define what those supports are, and part of what we're trying to do is do that. Define what those are. What do you need to have, and what's the best way of doing it? So a quality improvement team, a learning collaborative perhaps, leadership skills training perhaps. These are all things that we're going to be looking at to see how can we be as feasible, as fitting to the context, but also as helpful in terms of being able to sustain the model, because it costs a lot to get any new program up and running. So system redesign, let me just say recap a few things. The drivers, as I mentioned before, the accountability, cost reduction, and quality. And so this is part of the new world order. We need to face it, and I think we need to see if there are ways to take advantage of it, and I believe there are. Integration across systems. So Department of Mental Health, Department of Health, OCFS, OASAS, they are talking in ways that has never been true before. There are real conversations about how to integrate services. There are real conversations about how to integrate data across these systems. And this is a good thing, because it means that a separate mental health authority that is on its own, so to speak, is not likely to be part of the future, but it means that everything we've been saying for many years about mental health being a part of health, it's going to become a reality at an infrastructure level. And so I think we need to be aware of that, and also see what that means in terms of our training models and in terms of who is going to be delivering what services. There's going to be more emphasis on team-based and family-centered approaches, better, briefer, more durable services. I think that we have to see how much can you condense services without losing the quality, without losing the outcomes. And there's a danger in that, obviously. If we try to shortcut our services and make them too brief, we may not get to the outcomes we're looking at. But we have to see how can we be smart about that. Some features of a redesigned system, boy, this is even light for me. Single point of accountability, using data for evidence farming. So we think about evidence-based practices in terms of, here's a model, let's put it in place, let's study how to do it. That's not the only way to develop an evidence base. And more we're seeing examples of people that have, that entities have data systems that are tracking outcomes at every session. They're tracking specific indicators of outcomes or of an intervention at every session, and using that data in order to inform, well, gosh, we did this, this, and this, and look how the improvement is working for these kids and these families. That's a kind of evidence, and it's an important kind of evidence. And I think in the evidence-based practice arena, we sometimes forget that evidence can be homegrown, and so evidence-based farming is a term from Naiwa Dwan, which I think is a wonderful term. Feedback and communication systems, I'll talk a little bit more about that, but there are a number of them now that can be used, that can be embedded, and many agencies and clinics have their own systems too and are using those for improvement. Don Berwick, who basically, he was the head of CMMS, and he was from, or still is, I guess, Institute for Healthcare Quality, and in large part came up with some of the learning collaboratives, the original learning collaboratives. He's written a wonderful article in JAMA, From the Inside Out, and it's about the need for healthcare leaders to really come to the forefront now and to be driving changes in improvement, and how the changes that are happening from the ACA are leading to healthcare leaders becoming more and more important in terms of identifying quality. And so it's incumbent upon all of us to be helping to inform what those quality indicators should look like. So just in a few final thoughts, how to get there. I mentioned 3 dimensions and 4 dimensions. I think there are 4 ways in which we can be thinking about the work we're doing in systems in order to make them better. De-gilding, as we have a lot of guilds. We have social work guilds. My own profession, psychology, is a very guild-oriented. psychiatry, we all have those skills. How do we think beyond that? Driving with data, distilling our information down so that we can find the most robust combination, and democratizing access. So de-gilding. I talked about our parent partners and the work that they're doing in our multifamily group, but we're also using parent partners for lots of other things, for screening of maternal depression, for running particular skills groups, for being the patient navigators, for educating families about the systems and what mental health systems are all about. Working in waiver programs, we've had a large study to help the family advocates there be able to work with families to say, here are the services that are available to you, to be able to set boundaries. We have a huge workforce shortage in this state as well as in this country, and I think there are ways in which we can be thinking in a much smarter way about using our workforce differently and involving parent partners in particular. Youth partners and youth peer mentors are another part, burgeoning part of the workforce in New York State. And so I think there's some real opportunities for building on the expertise that youth peer mentors bring to the work. It's not something where you can just take somebody who's got experience and they're credible and stick them in the middle of one of these messy kinds of services. It doesn't work that way. But there is a kind of expertise, drive, motivation, and skills can be taught. So I think that's very important. And there's good research that's on this, that's beginning to get stronger and stronger on the way in which peer parents can become part of the workforce. Driving decisions with data, in a way this is kind of self-evident, and yet it's quite amazing how infrequently we actually do that, how infrequently we actually use data within either our sessions within our work in order to figure out, are we doing it as well as we could? So there are some models for that. Performance measurement is something that is being driven by the National Committee on Quality Assurance, NCQA. There are quality measures that are being used to measure the performance of healthcare agencies, healthcare industry. And they are largely for other health conditions. There are some for mental health, but here we go again. Those that exist for mental health are largely for adults, not for kids. Now this is important for us to get involved in. We have had the opportunity to work with NCQA to develop some quality measures on adolescent depression and the access to services, access to care, and pathways to care. We're doing the same thing with maternal depression. There are also quality indicators now around psychotropic medication prescribing for kids. But the truth is, we've got to get much more involved in this and develop our own. It can be homegrown, but we've got to develop some of our own, because otherwise they will be superimposed from without, and they may not be the indicators that we think most matter to kids and families, and then guess what? We're going to have to be doing it anyway. So I think it's very important for us to be thinking as a community about what do we think really matters, where are the outcomes we want, and how are we going to track that, and track it on a regular basis, frequently, so that we have the data to show that what we're doing is making a difference. Or if it's not, we will correct. One example of a clinical dashboard comes from Bruce Chorpita's work and PracticeWise, and we've been using this with our MAP training, which basically at every session, you decide with the family, what is it you want to track? What are the changes you most want to see? And you build that in as an indicator. You can also use standardized measures here. You can use the CANs. You can use whatever you're using already, along with homegrown measures. And then on the left-hand side are what you did, and this is drawn from the practice elements that I mentioned before, the core components of effective practices. And so those are specific techniques, elements, things that might have happened in a session. And you can see, is there a alignment between what we're doing, what the outcome is, and the changes that we want to see. The third D is distillation, And this comes, again, from Bruce Charpita and Eric DeLayden's work, and it's part of the MAP training. These are some of the elements, and it was derived from the evidence base, so some 700 randomized trials on the types of therapies that are effective for kids with disruptive anxiety, depression, trauma, autism. And basically boiled it down to a core set of about 27 or so elements. And so the idea here is that rather than training up the workforce on, first we'll do CBT for depression, and then we'll do parent management of this type, and then we'll do one for trauma, can we identify core elements that cut across the RCTs, and can we then provide training on those? To me, it's really smart. It's not traditional evidence-based practice thinking, however, because it's taking elements, and then it's trying to train people to be able to deliver those in a competent way. So it's a different way of thinking, but it's, I think, a very important one for trying to deal with the scale of the problem that we're dealing with kids and families, and the reality of how much training can anybody really absorb. Democratizing access. So there's a great book by Stephen Johnson called Where Good Ideas Come From, Natural History of Innovation. And he talks about a lot of technology innovations over the years. And one of the things I really appreciated about his book is that he takes a historical look at where we have come with innovations from the 1400s, basically, up to the present. This is don't even try to read the slide, but basically the idea is that you have innovations that can be categorized into four different quadrants, basically. You have those that somebody's going to make money from, and an individual developed it. So, we've got, what are some examples? The mason jar, vulcanized rubber, programmable computer. Then you have some that are marketable, as they're going to be sold, but they were developed by a network of people: planes, contact lenses, refrigerators. You have those that are not marketable, developed by an individual: Bunsen burner, stethoscope. And then you have this fourth quadrant, the non-market network. So it was not developed for a particular market, but it was developed by many different people, basically at once or sometimes working together. The periodic table, EKGs, pacemakers. And I was just curious whether we've seen some changes over time and in these quadrants. And basically we have. So I developed this based on his work. And you can see that since 1800, it's the non-market networked quadrant where we're seeing the most innovation. To me, this is really important. The innovations are coming not from proprietary products that are developed, that are sold, that are controlled and developed by individuals, but the real innovations are happening in this fourth quadrant, where there are groups of people that are networked. They're trying to make a difference. They're using data in order to improve it, and the object is to improve the quality, not necessarily to be part of the market. I think it's a very important and interesting phenomenon, and I think it's one that as a field we haven't paid sufficient attention to, but it has implications for the work that we're doing when we're trying to redesign a system. We can't use our business as usual models. It's not going to work. We have to be thinking differently. And so we're in a time where we have the opportunity to think differently and to take the knowledge that we've got, the opportunities with the policies that are in our faces right now, the healthcare policies, in order to design a system for children and families that's going to be around, that's going to help the entire life course of kids, that is going to be evidence-based, but that's going to be learning all the time, where we can have curiosity and learning built into how we redesign the system. And for me, that is going to be the best gift we can give to kids and families. Thank you so much.
Comments, questions for Kimberly?
Don't be shy. Yes.
I'm curious though, because you're also looking at populations that are significantly impoverished. Do you see it any ways that they be financially compensated for joining the workforce? Or
Oh, yes, they're paid.
Yeah.
Absolutely. No, absolutely, they are paid. So the parent partners are employed by agencies. We employ them in our CTAC center and also my research center. I've got 3 family advocates who I pay to be part of the research partnership. But the 400 or so I mentioned are employed in many different places. And the same thing is now happening for the youth partners. Now, I'm not saying they're being paid well, but absolutely, it's part of a professionalization of the workforce and a professionalization for peer work. Great question.
There's some like cross currents there as well, because that you see some community health worker kind of movement and so forth, where at some point in the history of that, there's a push toward credentialing and licensing and professionalization.
Yeah.
And it moves a little bit away from those community roots that it started at. So there's this sort of push at some point.
There's a tension there. Yeah, it's a great point. There is a tension, and we deal with that. We talk about that a lot because some of the family partners we work with are saying, we're not sure we want to become part of the professional workforce. You know, we're going to be co-opted then. You know, so it's a legitimate debate, I think. The professionalization has a lot to offer in that you are then able, as a parent partner, to inform the workforce. You're able to bring your skills to help change from the inside out and to then work with parents and be able to explain what the parents should be expecting about the services. But on the other hand, there is this sense of maybe we're losing our identity. Do we need to have some separateness as well in order to be true to our roots? And that's, I think it's a very legitimate conversation to have. My way of thinking is we don't need one or the other, we need both. So I would want to keep both really and keep communication between the two. Yeah.
Interestingly, my agency, the Francisco Racker Centers, has engaged in a pilot project to that end. And we have 3 family navigators
fantastic.
here with us today that we're not going the track of an official OMH family support parent partner, but a more grassroots,
Yes.
continuing to provide support, but not advocacy or goal direction, but
Yes.
support around any issues that may come up. So we do feel like it's an important part of the continuum
Yes.
to continue to work on, and we're looking for partnerships in the community and with schools, because funding is obviously a concern, and we're trying to be creative about how to continue it, frankly. So we're really lucky, though, that we have
That's wonderful.
navigators with us today.
Yeah, that's wonderful. And I like what you say about the continuum. I think we really do need a continuum of family support. And that means some independent family support. It means family support embedded within our programs. I mean, we need it all. Let's face it. We really need it all. So, yeah, thank you for that.
I was intrigued by your finding about how adoption of different innovation program was related to alignment between leadership and clinical staff. Can you just unpack that a little bit? And on what kinds of dimensions were you looking at alignment? I mean, was that kind of the climate and culture kind of scores? And so also, did you dig in a little bit to find out what was responsible for that alignment, whether there was like specific forums for discussion or ways that the rollout of the new innovation occurred that might have been responsible for that?
Yeah, good question. In that particular study, we were looking at the barriers and the facilitators that they identified as being reasons either that they did want to participate in some of the offerings or did not. And so it was very specifically about the types of barriers or facilitators that they identified. And some of those revolved around costs, some of them revolved around training demands, some of it revolved around values and attitudes. So, but what we found was that insofar as we had the directors of the agencies and the mid-management basically saying the same kinds of things, those were the organizations that tended to be prime and ready for doing some of this work. Now, what it is exactly that's going on inside them, we can only speculate. We do know that in those agencies where they have teams that meet on a regular basis, where there's clear role differentiation so that people know what their role is, there's clarity about that, there's communication about that, and it's going vertically up and down the agency system. So it's not just upper management talking to upper management, you know, and frontline talking to frontline, but there's an organizational team that's vertically structured. That improves the communication. It also improves the goal setting and the use of data. So we think that that has something to do with it. But, you know, that's part of the research that needs to be done around these organizational processes, which are absolutely critical for implementation.
On the common factors, so distillation.
Yes.
How do you envision professional development or education of people who are care providers rolling out in that model? And can you think of any examples where people are being developed to apply common factors rather than developed to apply a particular routine?
Yes, great question. There is a kind of training that we're doing now, actually, with the group called PracticeWise. And it is a fairly intensive training that we're offering to largely social workers, but and psychologists, but there's no reason it would have to be limited to that, really. And it's a 4-day in-person training, bookended with webinars, so it's actually 2 days in person and 2 days webinars, and then followed by 6 months of consultation around those particular distilled elements. So it can be taught. There is a website that you subscribe to, but it gives you access to all of the data. It gives you access to practice guides. It gives you scripts. You know, if I'm going to do cognitive restructuring with a child with 14-year-old Latina disruptive behavior disorders, what should I say? How should I start? It's that specific. It's really a wonderful resource, but it's not a quick fix, you know, because it does take, you got to figure out how to conceptualize a case, how to assess what the needs are, and it takes quite a bit of training, really. But to me, it's an intriguing way to be thinking about getting the evidence base out as much as we can and raising the bar for kids. We've just got to do a better job.
Maybe one more question. I see we're after 1 o'clock, so maybe one more question. Did that work, Janice?
At the beginning you talked a little bit about we're in this really pivotal time. It's a time of opportunity, and I'm wondering, given the bird's eye view that you have, whether you're more optimistic than pessimistic or vice versa. So being able to really serve kids and families in the way that you have learned is really effective.
Yeah. You know, it really, to be honest, it varies day by day. There are some days where I'm really optimistic. I think we can get this right. Talking to people, they understand it. We've all got plans that are coming together. I do some work nationally too with the Institute of Medicine, and there's a forum there on prevention for kids. Every major national agency and foundation and society is represented there, so it's a big group. Everybody gets it. They all get it. So when I'm talking with people that way, I get very optimistic. But there are days when I say, man, are we really going to be able to do this for kids? There's so much an investment on the adult side. Everything's being rolled out with adults. We know that managed care and focus on costs can be a real double-edged sword. It can help give you focus, but it can also mean go for the cheaper solution and cut the services and, cut everything down. And so I really do go back and forth. That's the honest answer.
Well, you've made us a bit more optimistic.
Good. Well, that's good.